morning, everyone. So I would be discussing the TPN practices at HIMS. I would like to thank my moderators, Girish sir and Chinmay sir. So moving ahead, the specific learning objectives for today, the indications that are set up, the components which is required for the preparation, the parenteral nutrition prescription, routes, the administration, monitoring, complications associated, the TPN apps, what we are using, the void in our practices, and the take-home messages. So the most common indications at our NICU, if of course the gut line can't be used due to any reason, extremely preterm babies, gut ischemia, gut injury or inflammation, surgical conditions, and infants too sick to receive enteral nutrition, shock requiring high dose of inotropes and pressors. So in these cases, we are going for TPN, but of course, from the TPN, we want to switch to the, we are taking care of the partial parenteral nutrition, and then of course, switching back to the enteral nutrition as soon as possible. So start the enteral feeds as soon as possible. Then the components, the macronutrients by carbohydrates, lipids, and proteins, and micronutrients by minerals, vitamins, and trace elements, and the energy derivation 40 to 50% from the carbs, and 30% from lipids, 15 to 20% from the amino acids. So in carbohydrates, we are starting with the 4 mg per kg per minute, and we're gradually increasing by 2 mg per kg per minute and up to maximum of 12 mg per kg per minute. And at this point of time, the RBS is monitored. We're trying to keep it in between 60 to 145 mg per deciliter. And the other side is the recommendations. Then the non-protein calorie nitrogen ratio, the CNR, it is measured time to time. And the derivation, the formula for this is the total non-protein calories divided by grams of nitrogen. And the target, what we're using is 150 to 250 kilocalories per gram of nitrogen. In proteins, we're starting with the 10% of amino vein. We're starting soon after the birth in the babies where the weight is less than 1500 grams. We are starting from 2 to 3 grams, and we are increasing to the target of 3.5 to 4 grams per kg per day, depending upon the growth of the baby. And if the baby is more than 1500 grams, then we're starting with the 2 grams and increasing to 3 grams per kg per day. So the 10% amino vein, what we are using, then this is coming in 2 preparations by 2 companies. And then we have the lipids. So we're starting with 1 gram per kg per day, and we're gradually increasing up to 4 grams per kg per day. The lipid, what we're using at our setup is SMOF, 20%, and this is 30%. This contains 30% of the soya bean oil, 30% of the MCT oil, 25% of the olive oil, and 15% of the fish oil. Now it has its own advantages: higher DHA, the sepsis rate, cholestasis, TPN-associated liver dysfunction, oxidative stress, and the phytoestrol load. They are all decreased by this. So we are using the SMOF, but in case of the logistic reason, if we do not have SMOF, then we are definitely going for the intralipid, which is 20%, the pure soya bean-based oil. So monitoring, we are going for a triglyceride levels. We are going generally at first 2 days, we are sending a triglyceride level, and after the initiation and adjusting of the lipid infusion. And when we are adjusting the lipid infusion, we might send at that time as well, and thereafter we're sending it weekly. So when the serum triglyceride level is more than 265, we're considering to decrease or stopping it depending upon the status of the baby. And in the electrolytes, we're going for the sodium. We're starting with 3 MEQ per kg per day with potassium of 2 and chloride of 3. So electrolytes, we're adding on the maintenance fluid after 48 hours of the life. These are the recommendations. What we are going, instead of the KCl, we're going for a pot phos. So I would want to just throw some light in this. So 1 ml of pot phos has 93 milligrams of phosphorus and 4.4 milliequivalents of potassium. We're giving by 0.5 ml per kg. And when added to the TPN IV calcium, we're using it separately to avoid the precipitation. And this is definitely reducing the risk of metabolic bone diseases at our setup. And I would also want to show some, so early supplementation of calcium and phosphorus, we are taking care of, again, in view of preventing the metabolic bone disease. So early supplementation involves calcium of 40 to 80 mg per kg per day, and phosphorus of 30 to 60 mg per kg per day. Then vitamins, we are going for a adult multivitamin preparation. Although the recommended vitamins for the newborn in the TPN has this adult vial doesn't contain the vitamin B12, ascorbic acid, and folic acid. So this is one disadvantage, but we're using this, and vitamins we are using along with the lipids. And to avoid the photo degradation, we're using the dark papers or the aluminum foils. And then in micronutrients and trace elements, these are the recommended dosage in the newborn. What we're using is the Otsky as a trace element. So this injection is of 3 ml, and 1 ml contains zinc of 1 mg zinc, chromium of 4 micrograms, and selenium of 22 micrograms with copper of 0.4 mg, manganese of 0.1 mg. And the dose what we have calculated roughly, if we want to cover the recommended intake in the babies, is 0.2 ml per kg per day. And this is costing us 163 rupees. Then other additives other than this, to make the TPN comprehensive, we are also going for a carnitine. In our setup, in the cases in which we're using is cardiomyopathy, as well as, of course, in the metabolic encephalopathy babies. Then a cysteine may be considered. We are not using it regularly in preterm babies for the essential amino acid, and it may be supplemented. It is supplemented as 30 to 40 mg per grams of the protein. Heparin we're using for the patency of the central venous catheters. We're adding it into the TPN by 0.5 unit per kg per hour. And despite of the fact that the baby is on TPN, we are practicing the buccal colostrum application and subsequently non-nutritive sucking depending upon the status of the baby. Then this is a TPN prescription for a 1.1 kg baby on day 4 of life. So the total fluid intake would be 140 ml per kg per day. This turns out to be 154 ml. With in the carbs, we're giving 10 mg per kg per minute, and that turns out to be, for this weight, 15.8 grams per day. Then since the baby is NPO, so then we're adding the proteins by 3.5 grams. That turns out to be 38.5 ml of aminovein. Similarly, lipids, MOF we're using. So this, for this weight, it turns out to be 22 ml and 3% NaCl, 6.6 ml with phosphorus, 0.6 ml, MVI, calcium gluconate, magnesium sulfate, and Otsky. So this all turns out to be 75.3 ml. So the fluid left for carbs, so this is 78.7 ml. So we have calculated the dextrose. So now we're mixing the two solutions. In one solution, we have aminovein, the sodium chloride, phosphorus, Maxer, Otsky, and the dextrose. And in another solution, we have the lipids and MVI. And we are, of course, using the calcium gluconate with a different peripheral line. So we have a TPN room at our center with the laminar flow. And so these are the pictorial presentation all everywhere in the TPN room. And so the preparation of the TPN, we are going for a laminar flow. We are cleaning with the disinfectant, the sterile sheet spread inside the laminar flow. The UV light is switched on for 30 to 45 minutes. Then the required materials are kept inside the laminar flow. And after cleaning each one of them with disinfectant, then we're using it. We're switching on for the light for 30 to 45 minutes, and the lipid, MVI, they're all cleaned by the chemical disinfectant and kept under it. And after switching off the UV light, the TPN is prepared after wearing the cap, mask, gown, gloves in a complete sterile manner after switching on the laminar flow. TPN is connected to the patient, and the bottle along with the tubes is to be changed every 24 hours. So the TPN with enteral nutrition, encouragement of TPN with enteral nutrition we're doing, and as TPN without enteral nutrition would lead to a decreased mucosal IgA production, the lack of trophic hormones, increased adhesive molecules and neutrophilic attraction, the TPN associated sepsis, SIRS, and mucosal atrophy, and hence we're trying to encourage the partial parenteral nutrition rather. The routes, what we're using is either central or peripheral. Peripheral only if it is given for a very short period. Otherwise, predominantly we're using a central lines for TPN. For the extended period, if the TPN is required for an extended period, then a use of double lumen catheter lowered the number of additional venous placements, but it was seen to be clogged, leaked, and broken more often. Then we have, so the preferred route is a central line, UVC or PICC. Then we have a single lumen versus multiple lumen. So we have seen that the double lumen catheter lowered the number of additional venous placement, but then it has its own drawbacks, clogged, leaked, and broken. PICC and tunneled CVC should be used for administration for prolonged parenteral nutrition during hospitalization. And the practice, what we are obsessed with and we are following it, is the catheter connectors, ports, and hubs to be disinfected before accessing with 70% isopropyl alcohol or sometimes chlorhexidine. So asepsis, while TPN preparation and thereafter, we all should be obsessed with the asepsis, and we are trying to create the awareness by in our NICU. Maintaining the OT-like preparation, all the fluid mixing and preparation under the laminar flow, infusion sets to be changed daily. The proper hub care is taken care of, and preparation solution we're not using beyond 24 hours. And inotropes and antibiotic is being given after checking the compatibility. Obsession with the asepsis, and then for the TPN, to prevent the TPN photodegradation, we are using the aluminum foil and the brown dark papers, although we have some lines also which are available in the market, but it is costly, hence we're not using it. Then bacterial filters, currently we're not using the bacterial filters because of the cost, but we're taking the aseptic measures while preparing it, so we're not using this. But we have two types of filters available. One is for the lipid lines, another one is for the one which is used for the aqueous lines. So the lipid lines, they're being changed every 24 hourly, whereas the aqueous lines 96 hourly, we're changing it. In monitoring, we simultaneously with the TPN, we are going for the monitoring every 6th hourly, we're going for a blood sugar. And initially we are using, we're doing it every 6th hourly, and later we are customizing it depending upon the status of the baby. Weight monitoring we are doing daily, but sometimes in the sick babies, we're customizing it to twice daily. Sodium, potassium, chloride, we're doing it twice weekly, whereas weekly we're going for calcium, phosphorus, magnesium, blood gases, CBC, LFTs, and anthropometry every weekly we're doing it. Which includes the head circumference and length. And triglycerides, we're doing it 1 to 2 days after initiation or adjustment of lipid infusion, and thereafter we're doing it weekly. So preparation should be baby specific and double check. Monitoring is key to successful therapy and managing the complications simultaneously. Weaning and stopping. The TPN at our setup, we are decreasing once the enteral feed of 50 ml per kg per day is achieved, and one may consider stopping when the enteral feeds are 100 ml per kg per day, and when TPN volumes are less than 25 ml. So using the gut line at the earliest, and enteral nutrition is more important than parenteral nutrition. Then complications, what we are facing mostly is triglyceride levels are high and neonatal sepsis. TPN difficult neonatal multivitamin preparations is not available. Neonatal trace element formulations are not available. And in order to overcome this, we are going for adult preparations. And cost of, since it is the lipid cost is 1,000 to 1,200, it's costing us per day. So we are going for a sharing. And since we're doing it under the laminar flow, so we are able to maintain the aseptic precautions here. Lab investigations and monitoring, sometimes it is, but mostly we're not facing this. Wide range in practice in parental and enteral nutrition, and smaller dispensing bottles, which is not available. So drug compatibility with TPN, we are going for a drug compatibility checking. So this TPN is usually incompatible with mixing with the drugs like ampicillin, phenytoin, furosemide, and phenobarbital. Incompatibility to be mixed in Y connectors. We are taking the help of Neofax, Lexicom, Medscape, and UpToDate for compatibility checking. Then the available apps, we have the neonatal AI, the Aspen clinical app, the Neo TPN. What we currently using is a neonatal AI. Most of the time we are doing a manual, but sometimes we're taking the help of neonatal AI. Voids to fill in our practice is the logistic reason sometimes, because it's costly, and the Ayushman process is taking time, and that's the reason most of the time we're facing. And lack of training and attitude, poor record keeping. And the take-home messages here are that the metabolic and nutrient demand of preterm is equal or higher than the fetus. So we should start with the TPN as early as possible. Hours and not days are the longest periods which neonates should be left without nutrition, either enterally or parenterally. TPN should be comprehensive and not just for the namesake. Laminar flow system should be a part of every NICU. So this is from my side. Thank you all.
Thank you very much, Dr. Prachi. I would say TPN is essential component of intensive care system, and we cannot take adequate care of them without the TPN practices. And asepsis is something which is most important. So I would like to, I would request Dr. Neha to start sharing the screen and deliberating on our TPN practices.
Good morning, everyone. Thank you, ma'am. So, I'll be presenting the TPN practices in SGBGI NICU unit. Thank you, ma'am.
Screen and just change.
Yes, ma'am. So I'll start with indications of TPN, components and the requirements of total parenteral nutrition, the laminar flow and what laminar flow are we using, precautions and aseptic.
I'm not able to see. I think we are seeing the previous slides only.
Yes, sir. Neha,
I think
slides are not visible.
Prachi should stop sharing her screen. Sir.
Okay, ma'am.
Oh, two screens are being shared at present.
Yeah,
I think
it's done from my side, ma'am.
Okay, I shall do it, ma'am. It is changing now, ma'am.
Yes.
Yes.
Good morning, everyone. So I'll discuss the indications and composition of total parenteral nutrition, the laminar flow and the type of laminar flow that we are using, precautions and aseptic methods while preparation of TPN, and the apps that we use. So as compared to preterm neonates, the term neonates rapidly adapt from a relatively constant intrauterine supply from intrauterine life to intermittent feeding of milk. Preterm neonates, due to reserves, are lesser, limited nutrient reserves, limited metabolic pathways, and increased demands are more late in adaptation of feeding. TPN, at our unit, we start total parenteral nutrition in all preterm neonates who are less than 28 weeks or less than 1 kg birth weight, or the neonates which are having surgical conditions like bowel atresia, post-op babies, CDH, or any baby who's in sepsis, shock, requiring inotropes, or NEC. So at our SGPGI unit, we have a PN facility with a dedicated TPN room, which is located away from the NICU of size about 140 square feet, a laminar flow system with a computer with printed for TPN charts, a refrigerator for different infusion pumps and nutrient solutions, and disposable and scrub linens. So this is our NICU. Our TPN room is located away. It is a clutter-free room containing only the laminar flow of size of 140 square feet. This is our laminar flow from Optimer Esco brand. So our daily routine is that just prior to rounds, the TPN trolley is prepared, containing the scrub linens, disposable sheets, the solutions for asepsis precautions, the disposable syringes, aminovin lipid solutions. They are being raised from the HRF by the morning staff of the allotted babies. Prior to rounds, the laminar flow is being cleaned, which I'll discuss in the following slides. And then the solutions are being kept in the laminar flow for 30 minutes in the UV radiation. And after the rounds and the daily chart preparation, one resident and a allotted staff nurse in the daily roster prepares the TPN. Most of the times, the half of percent of total parenteral nutrition is by the carbohydrates that gives dextrose. 30% is by the lipids, and next 10 to 15% is by the proteins. So we start with 60 ml per kg in babies more than 34 weeks or more than 1500 gram birth weight, and 80 ml per kg in less than 1500 gram birth weight babies. Daily urine output, electrolytes, and weight loss or weight gain is assessed, and then further increments are being made based on that. So if the dextrose composition is less than 12.5, we use mostly the peripheral lines. And if it is more than 12.5 or higher osmolar fluid, then we use central lines. The formula for calculation is percent of dextrose into per ml per kg per day divided by 144. In preterm babies, we start with a bit higher GIR, that is 4 to 8. And in term babies, we start with 4 mg per kg per minute. Daily increments of 1 to 2 mg per kg per minute are made, and maximum of till 12 mg per kg per minute GIR is being given. So apart from calculating from the TPN chart or from the apps, we calculate manually from 25% dextrose and 10% dextrose, assessing the amount of percent dextrose that we need and then crossing its composition. This is the formula for assessing life. If you want to prepare a 12.5% dextrose, we subtract it from 25. This comes 12.5, and 12.5 minus 10 comes 2.5. So this comes in a 1:5 ratio. So if we take one part of 25% dextrose, then 5 parts of 10D are being taken from the whole amount of dextrose. Let me use converted each of MCT oil and soybean oil, which provides basic essential fatty acids and high source of energy. So these are the components that we lipids of that 20% come at a price of 360 rupees per 100 ml. Aminovin is 10%, which is approximately 346 rupees per 100. 10%, 5%, 25%, and 50% dextrose bottles we use to make dextrose composition. And the electrolytes we'll further discuss. We start with sodium of 0 to 3 in first 2 days of life, and then we increase to maximum of 3 to 6 MEQ per kg per day. The sodium content that we use is 3% injection, 3% saline. For potassium, we start with 0 to 2 milliequivalents and then we increase it further to 3 MEQ per kg per day. For potassium, if we are giving it to preterm babies, we use injection phosphorus so that we give phosphorus also to the baby to prevent osteopenia of prematurity. And in term babies, we use KCl in IV fluid. The phosphorus injection is being added in aminovin so that it does not precipitate with calcium in the IV fluids. For calcium, we use 10% injection calcium gluconate at the dose of 150 to 200 mg per kg per day. 50% magnesium sulfate injection is being given at 0.1 ml per kg per day, and phosphate is provided by the phosphorus solution. So this is the phosphorus solution, but care should be taken to assess the potassium levels also, just giving prior to this. And because 1 ml of phosphorus gives 4.4 milliequivalents of potassium, 3 moles of phosphorus. The preparation that we is already discussed. The protein we use is 10%, SMOF 20%, 3% in sodium chloride for sodium, and 10% MBI, we use adult MBI solution because we don't have pediatric MBI solutions. As it has been already discussed that the limitation with adult MBI is it lacks ascorbic acid. But despite all the facts, we try to initiate nutrition. So for this, we do oral application of colostrum every 2 hourly, initiate non-nutritive sucking once the baby is stable, and initiate early feeding if the baby is able to take the feeds. Base elements, we use 2 injections. Both are in our HRF, injection salicylate or injection Otsky. This comes at a price of 100 rupees per vial. This provides chromium, copper, selenium, and zinc at 1 mg per vial. So to prepare TPN, first of all, these are the steps: patient identification. Daily TPN charts are being printed with a set proforma, the name, weight, present weight, birth weight. CR number is being depicted on the daily chart. Then after the rounds, the daily requirement is planned. Calculation of TPN is done by 2 methods at our unit, both by manual using our chart and other by the Excel, TPN Excel Performer. That is the software which is there in our nursing station desktop. Then the PN preparation and then administration. So to prepare, the first step is calculation, then the preparation and administration, which involves both priming of the tubings and then connecting, maintaining the line care. Manually, we do by TPN charts, as I've discussed, that the birth weight is used for calculation till it is regained, and after that, the daily weight is used for calculations of drugs. So this is our TPN chart, which we use, daily TPN chart that we use. This contains the total fluid intake at what ml per kg per day are we trying. We mark this whole volume here. From this whole volume, the feed amount, the drugs volume, the inotrope volume, all the infusions, antibiotics are being subtracted from this volume. This is the fat at what gram per kg per day we are trying. In all our volumes, we multiply this factor by 1.2 because this is the amount, extra amount that we need to prime up the tubings. So we divide the volume by 24 as per the original value, but we take extra 1.2% in every aminomin, lipid, and electrolytes level. At the end, after subtracting all the volumes, the dextrose concentration is assessed, and using the 25% or 10% dextrose, the required dextrose volume is written. So for example, we have this TPN chart of a baby with 3 kg birth weight and planning to give a total fluid intake of 150 ml per kg per day. So this volume comes out 450 ml per day. In this 450 ml, we try to subtract all the antibiotic infusions, feed volumes, and then this volume comes at 368. Then in the next step, we tried, this is the aminovin we are giving at 3 gram per kg per day. So this volume comes, suppose it comes at 78 ml. With 78 ml into 1.2%, we'll write hit 90 ml. So that the extra amount remains in the tubing and it is used for removing the dead space of the tubing. After this, the electrolytes, we use 3% injection NaCl. So if we are using 3% and we are giving it 3 MEQ per kg per day, then this comes at 3 into 3 into 2. This is a factor when we are using 3% NaCl. If we are using a 0.9% NaCl, then we use the factor 1. So for potassium, if we are using at 2 MEQ per kg, we divide it by half. If we are using calcium, 2 ml per kg per day, then we keep it as same 2 into 3. MgSO4 is added at 0.1 ml per kg per day. Phosphorus is added seeing the potassium values. And after subtracting all the values, the dextrose composition is prepared by 25% dextrose and 10% dextrose. Apart from this, we can prepare from 5%, 50% also. This is our TPN calculation Excel. The first column contains We need to enter only the first column things. Apart from this, all the other columns, the Excel sheet provides us. We need to enter the weight, the TFI, amount of feed volume, what we are trying to start 15 every 2 hourly, lipid at 1, amino min at 1, and all the things that we enter here. This gives us the total volume, the osmolarity, and the volume rate also. Discuss our laminar flow. I've discussed this is our optimal laminar flow. So preparation includes, we have daily CSSD trays for the prior preparation that are coming daily at around 8 a.m. and we start TPN trolley preparation at around 9 to 10 a.m. Just prior to preparation, we clean this laminar flow. The stainless steel part is being cleaned with 70% isopropyl alcohol, whereas the glass of the laminar flow is being cleaned with the soap solution. So cleaning is done from back to front and up to down. So after cleaning this with alcohol, we start on this monitor on this monitor, we start the UV radiation for 30 to 45 minutes of maximum. So when we start this UV radiation, the caution should be taken to that the glass is closed. If the glass is not closed, then UV radiation will not work. And prior to preparation of TPN, this can be switched on, and then the room should be closed. The UV radiation are carcinogenic, so there should be no one in the room, and room should be closed for this. Apart from this UV radiation button, we have this fan button also, the light button, which is during the preparation. Automatic versus manual preparation, we both do. There are 2 persons needed, 1 senior resident and 1 allotted staff nurse. They prepare under the laminar flow with surgical asepsis, and the solution is prepared for next 24 hours, and next morning other TPN is prepared. If the TPN is prepared afterwards, like in afternoon sessions, then we can store it in refrigerator. But once prepared, we do not add further things in the TPN bag. So these are the steps. We have a different hand wash area in our TPN room. The staff nurse adorns with surgical asepsis. The cleaning of vials after UV radiation also for 30 minutes. We clean the vials from top to bottom. Whole vials are cleaned with spirit betadine spirit with ANTT technique. And then the preparation into 50-60 ml and the desired amount of syringes is being taken. Labeling is done for each baby on the syringes. The amino bin and potphos is taken into 1 syringe. MVIs and lipids, because they are photooxidative and covered with aluminum foils, they're taken in another syringes. This is the final TPN preparation. So before connecting to patients, we prime up the tubings and we use the 3-way connectors. Aluminum foil coating of lipid syringes is done. We do not interrupt for medications and try to avoid from giving line where inotropes are being given, and infusion pumps are used for the same. Daily, the tubings are changed and the drip sets are also changed. For maintaining strict asepsis, line care is done. We label and cover with gauge piece all the entry points. IV filters are being used at our unit. They come at a price of around 250 rupees per filter. These filters, when they change the color, they need to be changed. And apart from it, if this filter do not change the color, we need to change it every 48 hours. So these are the stickers that we paste on the filter on what day it needs to be changed. Multi-clav, or the needleless connectors we have comes at a price of 300 rupees. These are the needleless connectors that we attach at the hub of line. So during preparation, in 1 syringe, we have taken aminoven, dextrose, and electrolytes. In another photoprotected syringe, we have taken lipid and MVI. We can give it through both peripheral line or central line. Mostly, if it is for shorter duration, we use peripheral line or low osmolar solutions, we give from peripheral route. Care should be taken to see the osmolarity of solutions. The high osmolar solutions are mostly like more than 1000 milliosmoles per liter. They are mostly the soda bicarb solutions, 50% dextrose, and 3% injections, 3% chloride solution. During the TPN, the monitoring, just prior to starting of TPN, we measure the serum triglyceride levels and then measure it once weekly. Daily electrolyte should be monitored and frequent changes in the composition should be made. The calcium, magnesium, and phosphorus should be measured every bi-weekly. These are the apps that we use. Mostly we use the Neonate AI app and the DexCal app to calculate the GIRs. And while doing the Excel sheet TPN, we mostly do not require these apps, but further, Kimaya and DexCal are the ones that we use mostly. So take home message is total parenteral nutrition is essential part in cases of preterm babies, but we try to start and initiate early enteral nutrition as soon as possible. Early aggressive nutrition should be started in those babies who are eligible for it. The prescription should be according to the age and clinical condition depicting the daily weight loss or weight gain. The labeling should be correct. And monitoring during the total parenteral nutrition is the key to successful therapy and to manage the complications of electrolyte disbalance, if any. These were my references. I acknowledge all the neonates, our HOD ma'am, and all the consultants, our residents, and all the sister departments. Thank you.
Thank you, Neha, for elaborating on the presentation. So we can move on to the next.
Good morning, everybody. My name is Dr. Moshmi. I'm a DNB neonatology trainee at Wadia Hospital, and I would be discussing about the TPN practices in our NICU. Dr. Kiran More, our head of the department, would be moderating my session. So we all are well aware about the indications for TPN. The common indications for TPN in our NICU are babies with a gestational age of less than 32 weeks or a birth weight of less than 1.5 kgs. And we also start TPN in most of our patients who have undergone surgical correction for gastrointestinal malformations like a tracheoesophageal fistula or intestinal atresia or omphalocele or gastroschisis. This is a common indication in our outborn section because we get a large number of surgical cases there. Discussing about the components of TPN, starting with proteins. These are the guidelines for initiation of proteins in TPN and the maximum dose that we can use in both terms and preterms. What we practice is we start amino acids on day 1 of life in both our term and preterm babies. In term babies, we usually start at a dose of 1 to 1.5 grams per kg per day, and we escalate it to a maximum of 2 to 3 grams per kg per day. In preterms, we are starting at a dose of 1.5 grams per kg per day on day 1, and we are increasing it to a maximum of 3.5 to even 4 grams per kg per day. What we use is 10% amino grain, the composition of which already my counterparts have discussed in the previous discussions. Talking about energy, these are the guidelines for the energy requirements on day 1 and the maximum goal of energy requirement in both term and preterm babies. What we do is we initiate TPN at kilocalories of 50 kilocalories per kg per day in both term and preterm babies. And in term babies, we target a maximum. In preterms, our target is 90 to 110 kilocalories per kg per day. Talking about carbohydrates and sugars, these are the guidelines for the glucose infusion rate in terms and preterms, the initiating dose and the maximum dose that we can use. So in both terms and preterms, we start fluids at a GIR of 4 to 6 milligram per kg per minute. In preterms, usually we start at 6 milligram per kg per minute, and the maximum GIR, which we can go till, is 12 milligram per kg per minute. We try to maintain sugars in between 70 to 150 milligrams per DL. Usually in babies less than 28 weeks of gestation or less than 750 grams, we start with 5% dextrose. And in babies 28 weeks of gestation and above, or 750 grams and more birth weight, we start with 10% dextrose. And then depending upon the sugars, we adjust the dextrosity and the GIR. Coming to lipids, these are the guidelines for starting lipids in terms and preterms. But due to high incidence of sepsis in our units, we usually do not initiate lipids on day 1 of life in preterm neonates. But when we start lipids, we usually start it at a dose of 1 gram per kg per day. In terms, we can go to a maximum of 3 grams per kg per day, whereas in preterms, we usually keep it at 2.5 grams per kg per day. So these are the various lipid emulsions that are available in the market, but what we commonly use is MOF lipid. And in some cases, we do use 20% intralipid. And as my counterparts have already elaborated on the difference between the two, we can see that intralipid has 100% soybean oil, whereas MOF lipid has 30% soybean oil, 30% of medium chain triglycerides, 25% of olive oil, and 15% of fish oil. Intralipid 20% does not have docosahexaenoic acid, DHA, and ARA. Coming to electrolytes, minerals, trace elements, and vitamins. So these are the guidelines for sodium and potassium supplementation in neonates. As we can see, what they have mentioned is on day of life 1 and 2, either you can skip giving sodium and potassium, or you may initiate them at doses of 2 to 3 milliequivalent per kg per day. What we practice in our NICU is that we do not give sodium and potassium supplementation for the first 48 hours of life. But when we start the supplementation, that is on day 3, we start sodium at 3 milliequivalent per kg per day in both terms and preterms. And in for potassium supplementation, we start it at a dose of 2 milliequivalent per kg per day. Sodium, we can go to up to 6 milliequivalent per kg per day, and potassium usually in term babies, we keep it at 2 milliequivalent per kg per day. In preterms, we can go to up to 4 to 5 milliequivalent per kg per day. So this is one different point. For sodium supplementation in our unit, we are using CRL, that is concentrated lingual lactate, 1 ml of which gives approximately 3 milliequivalents of sodium. For potassium supplementation, we are using potassium chloride, 1 ml of which is giving 2 milliequivalents of potassium. In cases where we are also giving phosphate supplementation, we do not add KCl because 1 ml of potassium phosphate gives around, it's actually 4.4, but 4 milliequivalents of potassium. Coming to calcium, phosphorus, and magnesium supplementation. These are the guidelines and the recommendations for calcium, phosphorus, and magnesium supplementation. We start calcium supplementation on day of life 1. We usually start it at a dose of 2 ml per kg per day, which gives around 180 mg per kg per day. Then monitoring the calcium, ionic calcium levels, we can go to as high as up to 8 ml per kg per day. We usually do not regularly supplement phosphorus and magnesium on day 1 of life itself. We supplement it only if it is deficient. So for phosphate supplementation, we are using potassium phosphate, that is POTPHOS, at a dose of 0.5 ml per kg per day. And for magnesium supplementation, we are using 50% magnesium sulfate at a dose of 0.2 to sometimes we can increase it to 0.3 ml per kg per day, depending upon the magnesium levels. Coming to vitamins and trace elements, these are the recommendations for the different vitamin supplementations that are required in neonates. So the A, D, E, and the B complex vitamins. As my counterparts have already described, pediatric MVI is not commonly available. So we too are using the adult MVI, and we usually use it at a dose of 1 to 2 ml per kg per day. And we start it from day 1 of life itself. Coming to trace elements. So these are the recommendations for trace element supplementation in neonates. And similarly, we are also using the Otsky injection for trace element supplementation at a dose of 0.1 to 0.2 ml per kg per day. Coming to preparation and administration of TPN. So we prepare TPN under strict aseptic precautions in the laminar flow room by designated staff, that is one nurse and one resident. Similarly, we also prepare dextrose, amino acids, and electrolytes as one solution, and lipids, vitamins, and trace elements as one solution. Both the solutions are connected to the same axis, that is the same line, but we are using a Y connector. Syringe with the extension tube which contains the lipid solution is covered with an aluminum foil to avoid lipid peroxidation. We are changing and preparing the TPN fluids every 24 hourly, except the lipid infusions, which we are changing every 48 hourly due to cost constraints. We prefer administrating TPN, particularly when we are using lipids via a central axis like a PICC line, a UVC, or a central line. And for antibiotics, blood transfusions, and other drugs, we prefer to use a separate IV cannula, peripheral IV cannula. So this is a picture of the laminar flow hood in our inborn section, and this is the one in our outborn section. So this is how our staff and the resident, they prepare the TPN fluids in the laminar flow hood. My counterparts have already described about the procedure in detail. And this is how the resident attaches the prepared fluids to the central axis of the baby. This is a photograph which is showing the lipid infusion being covered with the aluminum foil. Coming to monitoring of a baby on TPN. So usually we weigh the baby daily, head circumference and length on a 24-hourly basis, but in sick children, we also do it 12-hourly. The central axis site is inspected in every shift. Blood glucose is done once in each shift, do it once a day. Electrolytes, BUN, calcium, magnesium, and phosphorus, we monitor them 2 to 3 with SGPT and IM. Coming to monitoring of a baby on TPN, we weigh the baby daily. Head circumference and length we are assessing weekly. Input-output charting we are doing daily, and in sick children we are doing it 12-hourly. The central axis site is inspected in every shift. Blood glucose we are checking once in each shift, and thereafter twice a day. If the baby is stable, we do it once a day in the morning. Electrolytes, BUN, calcium, magnesium, and phosphorus we are monitoring 2 to 3 times a week. Hematocrit, bilirubin, SGPT, and phosphatase we are doing once a week. Serum triglycerides we are assessing once at initiation of lipid infusion, and then we are assessing it weekly. And also whenever we change the dose, we do monitor the serum triglycerides. A blood gas we are doing daily in extreme preterm babies, but in other cases we are doing them once at initiation and then weekly. So in sick children we do it bi-weekly. The common complications of TPN that we face in our unit is TPN associated cholestasis and catheter associated sepsis. Okay, so the take-home message for today is that early aggressive nutrition should be the goal. And in all those cases in which we are anticipating that enteral nutrition cannot be given for more than 5 days at a stretch, we should initiate parenteral nutrition. This strict asepsis should be maintained in the preparation of TPN as well as pertaining to the central axis that we are using for administrating the parenteral nutrition, and careful monitoring of the babies on TPN is also equally important. Thank you.